Hello, myself Dr. Leena Dhande, Professor Pediatrics at GMC Gondia, Maharashtra. Today I'll be talking about cyanotic congenital heart diseases in children. So how do we define cyanotic congenital heart disease? They are basically a structural heart disease in which there is mixing of deoxygenated blood into the oxygenated blood that is being pumped into the systemic circulation. This may be at various levels in the circulation, which we'll be elaborating upon subsequently. And this results in cyanosis or desaturation. So what are the causes of cyanosis in various structural heart diseases is something that we should understand. First and foremost, there will be certain structural heart diseases in which there's a right to left shunt. For example, tetralogy of Fallot. Second situation could be there is a right ventricular outflow tract obstruction, wherein the right ventricle has to generate excessive pressures to overcome the obstruction and pump blood into the right ventricular outflow. This will be seen in situations like severe pulmonary stenosis. This increased pressure in the right ventricle has some aftermath. The right atrium has to equally generate pressure so as to pump blood into the right ventricle with high pressures. Due to the increased right atrial pressure, there is opening up of the foramen oval, resulting in right to left shunting of blood at the right atrial level to the left atrium. The third situation is when any type of structural heart disease causes congestive cardiac failure, such as a ventricular septal defect, which in the first place is not a cyanotic heart disease, but it's an acyanotic or a disease which is not associated with cyanosis. However, when it results in congestive cardiac failure, there is pulmonary edema. In pulmonary edema, there is thickening of the alveolocapillary membrane. This alveolocapillary membrane is supposed to be very thin in microns so as to facilitate gas exchange to and fro. When it becomes thickened, there is a challenge to the effective gas exchange resulting in cyanosis. We all know that in children there are several pulmonary conditions like pneumonia, asthma, bronchiolitis, so on and so forth, in which there will be cyanosis. So there is a test called as hyperoxia test, which will help us differentiate pulmonary from cardiac causes of cyanosis. In children presenting to us with a saturation of oxygen less than 95%, we can do this test. First, we take an ABG sample, arterial blood gas sample. Then we give the child 100% oxygen inhalation for up to 10 minutes, following which we take the next sample of ABG. If in the post-oxygenation sample, the partial pressure of oxygen, PaO2, exceeds 150 millimeters of mercury, cyanotic heart disease is ruled out for all practical purposes. There are some exceptions, but this is the rule of thumb. In children who are suffering from persistent pulmonary hypertension of the newborn, there will be a variable response. Some of the children will show an improvement in saturation after 10 minutes of 100% oxygen, while other children will not. So cyanosis, as we know, is the blueness of various parts of the body. There are two types of cyanosis, central cyanosis and peripheral cyanosis. In central cyanosis, all parts of the body show blueness, whereas in peripheral cyanosis, only tips of fingers or toes will be showing the blueness. One important thing to note about cyanosis is that for it to be clinically visible, there has to be at least 5 gram% of reduced hemoglobin in the circulation. For example, in a child who is having severe anemia with a hemoglobin of say 2 or 3, the clinical cyanosis will not be visible. I've listed out the SpO2 or saturation of oxygen values in 3 scenarios. One is when there is arterial desaturation, the saturation will be less than 95%. When there is hypoxemia clinically, there will be saturation of less than 90%, whereas the clinical cyanosis will be visible only when the saturation drops to less than 85%. Why is this important to us? When the child presents to you with clinical cyanosis, he has already gone a very long way into state of desaturation. and therefore you have to take action urgently. Two more terms when it comes to cyanosis, very important for you to understand, are differential cyanosis and reverse differential cyanosis. These are two very peculiar scenarios which will be seen in children with congenital structural heart diseases. What is differential cyanosis? By differential cyanosis, we mean that the fingers will be having red color, whereas the great toes and the smaller toes, that is the toes of the feet, they will be having blueness. So why does this occur, and in which condition does this occur? It is because of certain open pathways which results in shunting of blood in particular places of the body, resulting in some parts being red and some parts being blue. The example which is given is when there are normally related great vessels, that is, the aorta is arising from the left ventricle and the pulmonary artery is arising from the right ventricle. So normally related great vessels. In addition to this, there is severe pulmonary arterial hypertension, and there is a right to left shunt through PDA. On the other hand, when we are talking of reversed differential cyanosis, there has to be a dextro transposition of great arteries, DTGA as we call it, along with the same two conditions that have been listed above, that is severe pulmonary artery hypertension and right to left shunt through the PDA. This will result in blue colored finger toe tips and red colored toes. Now coming to the classification of congenital cyanotic heart diseases. It is classified into 5 groups as per the physiology, as we call it. In group 1, there will be decreased pulmonary blood flow along with pulmonary stenosis and ventricular septal defect. The prototype example is tetralogy of Fallot. In group 2, there will be decreased pulmonary blood flow. Like in group 1, pulmonary stenosis is present. However, unlike group 1, the ventricular septum is intact. The classic example is valvular pulmonary stenosis. Group 3, again there is decreased pulmonary blood flow and there is pulmonary hypertension which is present. Classic example, Eisenmengerization. Group 4 and Group 5 are characterized by increased pulmonary blood flow. In Group 4, there is a parallel circulation. We'll come to that later. Example is dextrotransposition of great arteries. In Group 5, there is increased pulmonary blood flow in addition to having admixture type of lesions. Example, total anomalous pulmonary venous communication, single ventricle, single atrium, etc. So coming to the first group, in which there is a decreased pulmonary blood flow, pulmonary stenosis and ventricular septal defect. As I told you, the example is tetralogy of Fallot. There is progressive deep cyanosis and clubbing which is seen in these children, along with a single S2. Due to the pulmonary stenosis, the cusps of the pulmonary valve do not approximate each other and create a classic S2, and therefore the pulmonary component is practically missing, only the aortic component is heard, so we get the single S2. There is no cardiomegaly, no congestive cardiac failure, and what is very classic of this situation is hypercyanotic spells. So here I've shown a picture of a heart having tetralogy of Fallot, in which there's a ventricular septal defect, overriding of aorta. Aorta is committed to the right ventricle as well as the left ventricle. That is, it is getting blood from both ventricles across, and it is sort of sitting across the ventricular septal defect. There is pulmonary stenosis, due to which there is right ventricular hypertrophy. In group 2, there is decreased pulmonary blood flow with severe pulmonary stenosis and an intact interventricular septum. So we are seeing this in the picture. This is the level of narrowing of the right ventricular outflow tract. Here we have taken an example of narrowing at the valvular level. This causes the right ventricle to get hypertrophied because it has to generate higher pressures to pump blood out into the pulmonary artery against the narrowing of the pulmonary valve. In this condition, you will get increased pressure in the right atrium because the right atrium has to pump blood into the right ventricle, and the right ventricle is becoming less and less compliant because of its hypertrophy. The pressures are increasing. So here the right atrium is also going to have increased pressures. And due to this increased pressure, there will be opening of the foramen ovale. The foramen ovale is functionally closed in children and it closes later on. Now what happens is, it is like a flap valve. If the pressure in the right atrium increases, it opens onto the left side and the blood flows from the right to the left, resulting in a shunt, which is a right to left shunt, giving rise to cyanosis. Here again, the S2 or the second heart sound will be single with the same analogy that I told in the previous slide. And there's a likelihood of tricuspid regurg. The right ventricle is getting hypertrophied, later on it can get dilated, and the valve ring, which is supporting the tricuspid valve, will get kind of expanded to such extent that the cusps of the tricuspid valve will not be able to approximate each other, and therefore there will be occurrence of tricuspid regurg. In group 3, there will be decreased pulmonary blood flow along with pulmonary hypertension. So we will take a classic example of a ventricular septal defect, VSD, in which there is a left to right shunt in the ventricle to begin with. Therefore, it is acyanotic or there is no visible cyanosis. Due to this, initially there will be increase in the left ventricular volume, overload will be there. There will be dilatation and congestive cardiac failure. On the same side, the blood is going from the left ventricle to the right ventricle and is being pumped into the pulmonary arteries, causing flooding of lungs. This is what we called as, initially there's a hyperdynamic type of or hyperkinetic type of pulmonary hypertension. Later on, there will be reactive type of pulmonary hypertension in which the pulmonary arterioles will constrict and try to resist more blood coming into them. Later on, there will be development of irreversible changes of pulmonary arterial hypertension. All these changes will lead to right ventricular hypertrophy. When there is right ventricular hypertrophy, there will be reduction of the compliance of the right ventricle, increase in the pressures in the right ventricle, and thereby the shunt which was initially left to right will now become reversed and will become right to left, with the deoxygenated blood entering into the left ventricle, leading to the development of intense cyanosis. This condition was described for the first time by Eisenmenger, and hence it's called as Eisenmenger syndrome or Eisenmengerization. Group 4, as I told you, there is increased pulmonary blood flow with a parallel circulation. Example being dextrotransposition of great arteries. So as we can see here, the right atrium is emptying into the right ventricle. However, the right ventricle is emptying into the aorta. So the aorta, which should have been committed to the left side, is now committed to the right side. This results in the systemic circulation being parallel to the pulmonary circulation. I'll tell you what I mean. So blood is coming from various parts of the body through the superior vena cava and the inferior vena cava, collecting into the right atrium, going to the right ventricle, and then into the aorta, being supplied to various parts of the body, and then it is returning through the inferior and superior vena cava to the right atrium. So it's not going to the lungs at all. On the other hand, on the left side, the left atrium is getting blood from the lungs. It is pumping the blood into the left ventricle, and the left ventricle is pumping the blood into the pulmonary arteries. Pulmonary arteries take the blood to the lungs. From the lungs, again, it is coming back to the left atrium to the pulmonary veins, and then henceforth to the left ventricle and to the lungs again. So this condition is characterized by parallel circulation, and it is not compatible with life unless there is a communication between the two circulations, which may be at the level of the ventricles, It may be at the level of the atria, or it may be at the level of the great vessels in the form of patent ductus arteriosus. So this condition will be characterized by intense cyanosis, mild congestive cardiac failure, because none of the ventricles is having any resistance. So the heart is functioning well. Also, the lungs are not being flooded with excessive amount of shunted blood. So they will also be functioning well unless the size of the shunt is very big. And characteristically, always to remember, in this condition, there's a good likelihood that you'll have no murmur at all. Group 5, in this, there is increased pulmonary blood flow and there is admixture. What do you mean by admixture lesion? So there's going to be a single chamber, a place where the blood which is deoxygenated from the systemic venous return and oxygenated from the pulmonary venous return, they will be mixing and will be getting churned, right? So this may occur again at various levels. It may be venous, atrial, ventricular or arterial level. So as we have listed the conditions out, it may be a total anomalous pulmonary venous communication in which the pulmonary veins are draining into a common chamber and henceforth into the right atrium. Single atrium, when there's such a large ASD that it functions like a single atrium. Similarly, single ventricle, when the ventricular septum has not developed adequately, so it acts as a single ventricle. Truncus arteriosus and double outlet right ventricle. These may be mixing chambers at the level of the great arteries. Due to the great degree of churning and mixing of the oxygenated and deoxygenated blood, there is mild cyanosis. It's not intense. And due to all this blood being pumped into various parts of the body, it's flooding into the lungs, and both the chambers of the heart are over functioning because of that high amount of output which is mixing in that admixture chamber. There is a very high likelihood of CCF, congestive cardiac failure in infancy, associated with cardiomegaly. Multiple murmurs are there, and due to the flooding of the lungs, there's a very high likelihood of pulmonary hypertension. Now let us focus on the prototype of cyanotic congenital heart disease, which is tetralogy of Fallot's. This is the condition which belongs to the first group, that is decreased pulmonary blood flow with pulmonary stenosis and ventricular septal defect. So as we can see, there is a very characteristic ventricular septal defect which is on the outlet part of the ventricular septum. The overriding of aorta is there on this ventricular septum, or rather on the ventricular septal defect, that is the aortic valve. It is placed in such a manner over the ventricular septal defect that it will be getting blood from the right as well as from the left ventricles. Thirdly, there will be right ventricular outflow tract obstruction, and due to this there will be right ventricular hypertrophy. Now let us see each of these components in detail. So firstly, let's look at the right ventricular outflow tract obstruction, which is one of the most important components of a tetralogy of Fallot's. The level of the obstruction and the degree of obstruction may vary. The level may be subvalvular, in which there may be a stenosis, or there may be progressive infundibular hypertrophy. So by this I mean that by stenosis I mean that the stenosis might have been there since birth. However, when we talk of the progressive infundibular hypertrophy, it's a dynamic process and it is progressive. It is occurring in a progressive manner over the lifetime of the child, and therefore initially, though the child may be having a normal structure of infundibulum, later on he may be having a greatly hypertrophied infundibulum, and this will lead to problems to the right ventricular outflow. Valvular stenosis, there may be either a stenosis or there may be an atresia or there may be an absent valve. Now, absent valve physiology is going to be completely different from stenosis or atresia of the valve. In absent valve, there will be actually just the pulmonary trunk is arising on top of the infundibulum and there is no interposed valve. Now, what is the problem due to this? All the output of the right ventricle is being flooding into the uninterrupted by the valve. It's flooding into the pulmonary vascular bed. Supravalvular level of right ventricular outflow tract obstruction may occur because of stenosis of the pulmonary trunk. There may be hypoplasia of the artery. There may be atresia of the artery sometimes, or there may be a peripheral pulmonary artery branch stenosis. What happens due to this RVOT, as we call it? Due to this obstruction, there will be more and more blood going into the aorta rather than into the right ventricular outflow tract and thereby to the lungs. So all the deoxygenated blood from the right ventricle has got only two outlets. It will go either into the right ventricular outflow tract or it will go into the aorta. So greater the RVOT obstruction, more blood will be entering into the aorta. Secondly, the greater the degree of obstruction, there will be earlier age of presentation and there will be greater degree of right ventricular hypertrophy, because right ventricular hypertrophy is directly proportional to the whatever impediment to the outflow of the right ventricle. So it has to overcome that obstruction, so it will hypertrophy in a greater manner. Now there's a condition called as pink fallows. So we have heard of tetralogy of Fallows, called tetralogy because there are 4 components. Now what is pink fallows? This child has got all the components of tetralogy of Fallows but apparently is not as blue. He's in fact looking like a normal child. So this is because there are 2 components which are different than the conventional tetralogy of Fallows. First component is that the VSD is smaller in size and the right ventricular outflow tract obstruction is less severe. Due to this, the right ventricle will be emptying primarily into the pulmonary trunk and the left ventricle into the aorta, and therefore there will be less degree of cyanosis. However, because of the less severe RVOT obstruction, the blood is going into the lungs and therefore there may be some degree of CCF and pulmonary hypertension in these children. Now we have to understand the embryology a little bit to understand how the structures, various structures in the cardiovascular system are maintaining the pulmonary circulation. One thing could be that the pulmonary circulation, the pulmonary vascular bed is getting the blood only through the obstructed RVOT. That's one situation. Second situation could be if the RVOT is completely atretic, right, or there is a severe stenosis, then some other structure is needed to pump the blood into the pulmonary trunks. These could be of 2 types. One could be the patent ductus arteriosus, but this is risky because this patent ductus arteriosus has got a habit, is physiologically designed to close at 24 to 48 hours. Therefore, this could be life-threatening and it becomes a ductus-dependent circulation. This is very important. A third scenario could be, there could be major aortopulmonary collaterals, MAPCA as we call it, which will be usually the bronchial arteries, which will be communicating between the aorta and the pulmonary vessels. Now coming to the component of septal override of aorta, as we can see it here, this is the pink one, the white one is the aortic, this is the pink is the aorta and the white is the aortic valve, and it is sitting right over this ventricular septal defect. So all the blood from the right ventricle as well as left ventricle has got a potential to enter into the aorta. So when do we, like we also have heard of the condition double outlet right ventricle. So when will we say it is DORV and when will we say that it's a septal override? So conventionally it has been decided that if the degree of override is more than 50%, it is a DORV, and if less, we call it as septal override. Also, one anatomical characteristic has been looked into when calling it DORV or septal override, and that is the fibrous continuity between the aortic valve and mitral valve. If it is preserved, then we will say that it's a septal override, and vice versa. If it is not preserved, then it will be called as a double outlet right ventricle. Now, as we said, the ventricular septal defect is usually non-restrictive, that is, it's pretty large, and subaortic or outlet in location. And this is what favors all the blood, which is the deoxygenated blood from the right ventricle, to enter into the aorta. Now, coming to the component of right ventricular hypertrophy, it is progressive. It may not be there to that extent at birth, but as the RVOT increases, as there is infundibular muscular hypertrophy occurs, there is also more and more impediment to the right ventricular pumping of blood, and therefore more and more hypertrophy occurs. This results in a progressive reduction in the right ventricular compliance and thereby increases the degree of right to left shunting and thereby cyanosis. So the baby at birth may not be having that much degree of cyanosis, but as he grows, the cyanosis goes on increasing. So what is the course of disease taken by tetralogy of Fallot? So usually the children present in neonatal life with cyanosis, and this increases progressively. One very peculiar characteristic that is to be remembered in these babies is that when they start crying, there is increase in the degree of cyanosis. Second thing is the cyanosis is associated with clubbing. So as we know, there are two common symptoms that they are associated with each other for various physiological reasons that we already know. Third thing is hypercyanotic spells are characteristic of tetralogy of Fallot. We'll come to that in detail. Fourth is squatting episodes. What happens due to this high degree of cyanosis? The body perceives the cyanosis as hypoxia, and thereby there is increased secretion of the erythropoietin by the juxtaglomerular cells. This causes polycythemia. Due to the polycythemia, there is kind of sludging of the circulation or hyperviscosity, as we may call it, resulting in a thrombotic diathesis. More and more cells being produced in the body, they will be degenerating also, they will be dying also, and there will be generation of more and more uric acid. So this will lead to hyperuricemia. In general, these children are having poor growth due to the cyanosis. Whatever structural heart diseases we see, congenital heart diseases, whether they are cyanotic, acyanotic, whatever, there are various jets which are generated, which are impinging on the endocardium, on the endothelium, and all these things. And due to this, there is a denudation of the lining of the vessel or lining of the heart chambers. These areas of denudation become foci for bacteria to be lodged into it. We all have small degrees of bacteremias that are occurring, but our immune system takes care of it. But once these bacteria get embedded into these small foci of denudation on the vascular or the cardiac chamber and endocardium, as we call it, then they form a very safe haven over there. And there the immune system is unable to penetrate. And then these bacteria go there, resulting in the formation of vegetations. This is called as infective endocarditis. So we have to remember that these children are susceptible to the development of infective endocarditis, and whenever they are being subjected to any surgical procedures or endoscopies, then they should be given antibiotic prophylaxis beforehand to cover up for the possibility of bacteremia and thereby prevention of infective endocarditis. An important component of tetralogy of Fallot's symptomatology is the possibility of development of stroke and brain abscess. So how does this occur? Whenever there is a shunting of blood from the right side of the heart to the left side of the heart, we have to remember that it is bypassing the filtration in the pulmonary bed. So normally we look at the lungs as only a gas exchange organ, but remember it has got several other functions. And one of the functions is filtration. Filtration of the microemboli, which may be circulating in the body on the right side of the right side of the circulation. Second thing is, whenever the blood from the guts is entering through the liver into the right side of the circulation, some small amount of bacteria are likely to enter into the circulation because the gut is teeming with bacteria, as we call it. So what happens is the lungs act as a very important immune organ where these bacteria will be taken care of and eliminated. Now, if these two functions do not occur, then these microemboli, these bacteria, will be going right directly from the right side of the circulation to the systemic circulation and get lodged in vital organs, and important amongst these is the brain. This can result in stroke and brain abscess. I mentioned about the hypercyanotic spells. Now I'll be elaborating upon it. So hypercyanotic or TET spells. TET stands for tetralogy. Okay, so TET spells. These are commonly seen in children with tetralogy of Fallot and some other conditions. The age group in which it is seen is 2 months to 2 years generally. And why it is generally not seen after 2 years is because the children learn to bring into action certain protective mechanisms, and these protective mechanisms are called as squatting mechanisms. We'll be coming to that later. The duration of the hypercyanotic spell could be ranging from minutes to hours. And one important point to remember with respect to these spells is that they can occur irrespective of the pre-spell level of SpO2. Therefore, they can occur in children who may be mildly cyanotic or as well who are deeply cyanotic alike. The point is, those children who are mildly cyanotic have not developed the protective mechanisms like polycythemia for efficient carrying of oxygen, and therefore they are also like to develop complications due to the hypercyanotic spell. So what exactly happens is during the hypercyanotic spell, a child who is kind of who gets up early in the morning after very deep sleep with a very sensitive respiratory center due to that deep sleep, there are various postulations. So I'm just telling some of them to you. So he gets up after a deep sleep, his respiratory center is hypersensitive now, and he is having a sympathetic overdrive. Now, why does he have a sympathetic overdrive? Because it's morning hours, he has got up after a long sleep, so he's very hungry, he has passed urine, motion or something and is irritated, so he's crying, and all these things results in a very high sympathetic overdrive, as we call it. So what is to be remembered is when we have seen the infundibulum, the structure of the infundibulum, it's a funnel-shaped structure at the top of which is situated the pulmonary valve, and across beyond that there is the pulmonary trunk. So the infundibulum is a very muscular structure and has got a very rich innervation by the sympathetic system. So when there is a high sympathetic overdrive, there will be constriction of the infundibulum. The infundibulum is the first part of the right ventricular outflow tract, and when it constricts, there is a resistance of the blood which is passing through it from the right ventricle. Due to increased RVOT obstruction, more and more deoxygenated blood will rather go into the aorta where there is no obstruction, and this will result in increased cyanosis levels. At the same time, there will be fast breathing. We'll be coming to the algorithm shortly, how this occurs. Here it is. So the child who's crying is in pain due to some reason, has an infundibular muscle spasm, increased right to left shunt. This deoxygenated blood is being circulated to the body. The body perceives it as hypoxia. Due to hypoxia, there's going to be anaerobic metabolism resulting in acidosis. So the acidosis, the hypoxia, both are going to cause a constriction of the pulmonary vascular bed. And this again will increase the RVOT obstruction, and therefore there will be more and more right to left shunting. So as you see, this we have understood how it leads to more and more. This is a vicious cycle in which the child gets stuck of more and more hypoxia, which is perpetuating still more hypoxic situation. The second thing that happens is due to the acidosis and hypoxia, the body perceives this and wants to wash out all the CO2, and therefore it increases the respiratory effort, causing more and more tachypnea. Acidosis, we all know, is associated with hyperventilation or acidotic breathing. So there will be a deep breathing as well as a tachypnea. So both the things are occurring. Whenever a person has deep breathing efforts or tachypnea, the negative pressure in the thorax increases with each breath, and therefore more and more blood from the systemic circulation is pulled into the vena cava. This blood will be drained. So the preload into the right atrium and then into the right ventricle will be increased. And this again leads to more and more right to left shunt. Right? At the same time, there could be certain situations like, for example, if the baby is crying and is dirty due to potty or urine passage, the mother will feel that, come on now, let's give it a hot bath. So when the mother gives the baby a hot bath, there will be vasodilatation in the skin beds, the capillary beds in the skin, which will reduce the systemic vascular resistance. And this will again increase the right to left shunting. Similarly, this may occur due to sepsis or vasodilating drugs. So all these situations contribute to each other, and the child gets stuck into this vicious cycle, and therefore there is more and more cyanosis, which is perpetuating more and more deoxygenated blood entering into the left side of the circulation, more hyperapnea, and due to all this deoxygenated blood in the circulation, the child is likely to develop cerebral hypoxia, due to which there can be convulsions, altered sensorium, and sometimes even death. So there are certain situations in which, okay, first let's go to squatting, then we discuss it. Let's talk about management of the TED spell. So there may be situations that the child may be brought to you for the first time with a TED spell, or it may be a known case of a cyanotic congenital heart disease, and you have got the parents before you coming to you repeatedly with the child landing in a TED spell. So you have to train the parents, okay, when the first time they have understood that yes, now my baby has this disease and he's likely to land up in TED spells often. So you should tell them that when at home, they should do these 4 steps as first aid measure. Okay, amongst these, the 3 steps are absolutely necessary. The 4th step is as per requirement. So what are these steps? You have to tell them that whenever the child is crying and irritated, they have to pick up the child and soothe the child, try to calm it. Try to find out why the child is crying. Is it hungry? Then feed it. Is it wet, dirty? Clean it. Okay? And very, very important is keep the child in the knee-chest position. So this knee-chest position is what we'll be showing you later, in which the knees and the thighs, I mean the hip joint and the knee joint, both the joints are completely flexed such that the knees are pressing onto the baby's abdomen. Okay, now I'll tell you how this situation will help the baby to get relieved from the TED spell. Right, now what happens is, when the child, you all know about the femoral arteries and the femoral veins which are traversing through the inguinal region. So when you flex the thighs onto the abdomen, right, so it happens that the femoral veins are obstructed, they are kinked, and due to this the venous return from both the lower limbs is reduced to the right side of the heart. Secondly, the femoral artery is also kinked to a large extent. Therefore, there is increase in the systemic vascular resistance which is being faced by the aorta. So due to this, what we saw in the previous slide, just go back to it. Okay, it's not going back. What happens is more resistance is encountered at the level of the aorta, and reduced venous return reduces the preload blood which is entering into the right ventricle. Therefore, the right to left shunting will be decreased and the child's TED spell may get aborted. Another point the parents have to remember is, if the child has got fever, they should give a antipyretic, because fever also causes vasodilatation and reduces the systemic vascular resistance, thereby increasing the right to left shunt. If these first aid measures are not effective in reducing the child's cyanosis, hyperventilation, and the child is still irritable or going from bad to worse, then they have to bring the child to the hospital. What to do in the hospital has been listed here. Okay, so the most important thing is manage the baby in the mother's lap. This will reduce anxiety. Remember the point I told you about sympathetic overdrive resulting in the precipitation of the dead spell. So if you keep the baby in the mother's lap and then do whatever measures you are undertaking, then there will be at least some degree of reduction of anxiety in the baby's mind, and therefore the sympathetic overdrive will be decreased. As far as possible, reduce the number of pricks and number of tubes that you're going to insert for the baby, because this will again lead to pain. And as you know, in the previous slide, we saw how pain will contribute to increase in the sympathetic activity. So oxygen is to be given by mask. Start IV fluids. Okay. And now coming to the medications. So IV, intramuscular or subcutaneous morphine, whichever way is possible for you depending on the condition of the child, give it, because morphine will reduce the pain and anxiety and cause some degree of sedation in the child. And this will directly have a negative feedback effect on the sympathetic overdrive and will abort the dead spell. Another very important drug which is in our armamentarium for managing the TET spell is the beta blockers. So you can give IV propranolol or IV metoprolol or IV esmolol, which are very effective in again aborting the TET spell. There is another group of drugs which can be effective for this, which is the alpha adrenergic agonist. So what does the alpha adrenergic agonist do? It causes systemic vasoconstriction and has minimal cardiotonic effect. So due to this, there is an increased systemic vascular resistance, and therefore the aorta gets a resistance. Okay, so since the aorta is pumping blood into the systemic circulation, if the systemic vasoconstriction occurs, then less amount of deoxygenated blood will enter into the aorta. What do the beta blockers do? Yes, if you give, for example, you give propranolol to the child, then how does it abort the TET spell? It is a anti-sympathetic drug, and therefore sympatholytic drug as we'll call it, and thereby it will be having an effect of aborting the TET spell. There are some more drugs. If the acidosis is not relenting, you may have to give IV soda bicarb, but make sure that the ventilation is properly established and only then give IV soda bicarb, because it will result in generation of CO2 which has to be washed out through effective ventilation. So if the child is having coma, is not improving the ventilation, there's some going into hypoventilation phase due to the coma or raised intracranial pressure, then you'll have to first mechanically ventilate the child, and then you'll have to give IV soda bicarb. Sometimes you may have to give and send the child for an emergency palliative shunt if nothing at all is working out. So rather than treat the spell which has got a very high mortality, it's a good idea to know how to prevent these spells. So the most important thing is we should know how to counsel the parents. I've told you the points on which they have to be counseled about first aid at home, which is to be given. So regarding that, we have to tell the parents. Secondly, you have to start the patient on oral propranolol in doses which I have mentioned here, till the patient is posted for surgery. And surgery has to be really done as early as possible, because sometimes these spells can be life-threatening. One important point, especially in our Indian scenario, is that children who have got iron deficiency anemia are known to have a very high incidence of development of spells. Therefore, you must treat the iron deficiency anemia. These children may look, plethoric, so we may feel that they've got a lot of blood in their circulation, but if you look at it, it's more due to polycythemia. So if you see the RBC indices of each individual cells or each individual RBC, then it will be observed that they are microcytic hypochromic cells, because in a given amount of available iron, exponentially more number of RBCs are being synthesized in the bone marrow. Therefore, the iron is falling short in each given cell. That is iron deficiency anemia. And therefore, we need to correct it, because if not corrected, it can precipitate spells at a much higher frequency. So here we are going to show you what is squatting. So this is the typical position in which Indians sit over the Indian style toilet. And as you can see, it's also something like a knee chest position. So there's flexion at the hips and flexion at the knee joints, resulting in pressing of the thighs on the abdomen. So this is how squatting, as I told you, helps in controlling the TED spell and aborting it. So there's a decrease in the venous return from the lower limbs, increase in the systemic vascular resistance, increase in the pulmonary blood flow thereby, and thereby reduce cyanosis. So generally squatting, as I told you, it's a position in which people sit on the toilet. So if you have a child who is say 5 or 6 years old, 7 or 8 year old, as he's growing older, then he finds it embarrassing. He's feeling breathless. He's feeling that now he's going to go into a TED spell. He wants to prevent it. But he may find it embarrassing to sit in the squatting position in the middle of a social gathering or a classroom or something. So then there are some squatting equivalents that children adopt or adolescents adopt so as not to embarrass themselves. So they may be sitting on a chair with flexed limbs or something like that. So how do we investigate these children with cyanotic heart disease, cyanotic congenital heart diseases? We must do the CBC, hematocrit, look at the RBC indices as I told you. Then basic investigations may vary as per the presentation of the child. The patient, if we are suspecting, say, infective endocarditis, then you may have to go for blood culture, CRP, and look for various foci of bacteremia such as dental caries, so on and so forth. In addition to this, you must do ECG, X-ray, 2D echo, which is a very basic workup for every child with a heart disease. And when you're planning surgery, you may have to go for cardiac cath, angiography, MR angio, and such investigations. Now, this is a structural cyanotic congenital heart disease, tetralogy of Fallot, and the definitive management is surgery. There are two types of surgeries though. One is the corrective surgery, which is the definitive management, and second is the palliative surgery. So there may be some children who may be having certain comorbidities due to which they become a very high risk for corrective surgery. Therefore, we want to buy time, and in this situation, we do palliative shunts or palliative surgeries. On the other hand, the corrective surgeries, they should be undertaken as early as possible. In the children who are very critical at birth, it may be taken in the first month of life, but if not, at least it should be done within the first 6 to 12 months of life. Now, the advantage of doing the corrective surgery as early as possible is that it will establish normal blood flow through the pulmonary vasculature, and thereby it will allow these blood vessels to develop appropriately. So if you plan the surgery at a very later date, then it's possible that the blood vessels, the pulmonary blood vessels, are hypoplastic, and therefore they will not respond to that extent if it is done earlier. We all must know that the government through Rashtriya Bal Suraksha Karyakram RBSK arranges for free surgeries for congenital heart disease children, but some of the children may not qualify for it. So we must also know that there are certain centers who will do free CVTS surgery irrespective of BPL cards. So here I have shown you the palliative surgical management, the various shunts which are possible. The classic Blalock Taussig shunt is demonstrated here, in which the subclavian artery is being dissected here. It has been, truncated here and turned and connected to the left pulmonary artery. So later on, they felt that rather than cutting it that way, what you can do is interpose a Gore text shunt, which is a artificial material tube between the subclavian artery and the pulmonary artery. So the corresponding side pulmonary artery, the same side as the subclavian artery. Then we have got the water stunt shunt and the pot shunt. So the water stunt shunt is between the ascending aorta and the right pulmonary artery. The port shunt is between the descending aorta and the left pulmonary artery. So these are various palliative surgical managements, as I told you, in children who are high risk for surgery due to comorbidities. And here we have shown the corrective definitive surgical management of tetralogy of Fallot, in which they will be closing the VSD, okay, with a patch. Then the right ventricular outflow tract obstruction will be corrected by means of resection of the infundibulum and placing an outflow patch which will render the obstructed RVOT as more capacious, more spacious, and thereby accommodating the right ventricular outflow. And this will automatically revert back the right ventricular hypertrophy which has occurred over the time.